Greetings. This principle of double effect is very significant in healthcare ethics, and it pops up in the ethical and religious directives for healthcare services. And there's also a particular case I want to share with you that helps illustrate it. This won't take too long, but let me tell you how this principle works, and you'll see that it's often called upon. Think, for example, if there's an action you're wanting to take, and you know there's some possibility that another outcome will occur besides the one that you intend, is it still ethical to do so? And the more that you believe that unintended consequence will occur, does it become more tentatively ethical? That's what we're dealing with here. Let's see if I can help that. We begin with non-maleficence. Remember, that's one of the four principles that Beecham and Childress give us: autonomy, beneficence, non-maleficence, and justice. Non-maleficence means do no harm, and beneficence means do good. And so we articulate these in terms of four norms. One ought not to inflict evil or harm. It's a norm because that's something we're all likely to agree on. Another thing we're all likely to agree on is that one ought to prevent evil or harm. A third one ought to remove evil or harm when you have the resources to do so. And finally, one ought to do or promote good. Those are the non-hierarchical norms of non-maleficence and beneficence, and they lie behind our understanding of the principle of double effect. When we look at non-maleficence, here are some examples of the rules, and actually, if you remember, Bernard Gert's moral rules theory, we listed 10 of them there, 10 possible rules. Beecham and Childress in their explanation list these 5. Don't kill, don't cause pain or suffering, and so on. And these are rules of non-maleficence, things you will not do. They're don'ts. Don't do these things. Now, 4 conditions of the principle of double effect. If you're going to claim that the principle of double effect justifies your chosen action, these conditions must be met. First, the act itself must not be morally wrong. For example, the act must not be intending to kill someone. That would be morally wrong. Second, the bad effect, that is the unattended, what you call the unintended outcome, but actually the bad effect must not cause the good effect. We'll explain this more with a case here in a few minutes. Third, the agent, the actor, must not intend the bad effect. It can only be incidental. It cannot be intended as an end to be sought. And finally, the bad effect must not outweigh the good effect. Well, the bad effect is what we're eventually going to say is our unintended consequence, because according to those 4 norms, we would not intend a bad outcome, a bad effect. We would only intend good effects. Here's an example, a non-healthcare example. A terror bomber aims to bring about civilian deaths in order to weaken the resolve of the enemy. When his bombs kill civilians, this is a consequence that he intends. The tactical bomber, on the other hand, aims at military targets while foreseeing that bombing such targets will cause civilian deaths. When his bombs kill civilians, this is a foreseen consequence, but it's an unintended consequence of his actions. Even if it is equally certain that the 2 bombers will cause the same number of civilian deaths, terror bombing is permissible while tactical bombing is not, terror bombing is impermissible while tactical bombing is permissible. You see the difference? It's all about intent. Here's another example, and one more commonly used in healthcare. A doctor who intends to hasten the death of a terminally ill patient by injecting a large dose of morphine would act impermissibly. Now, let me explain. Many of you know this, but as you increase introduction of morphine into the body, it represses respirations, and the continued repression of respiration ultimately results in death. So a doctor who intends to hasten the death of this patient with a large dose of morphine would act impermissibly because he intends to bring about the patient's death. He's not just trying to relieve pain, because a doctor who intended to relieve the patient's pain with the same dose and merely foresaw the hastening of the patient's death would act permissibly. Even if the doctor knew that this was going to be a likely secondary outcome, it's still ethical because his primary purpose was to reduce pain. Now, this one is one that you may choose to argue about, but it's a great example of how the principle of double effect works. The principle of double effect, then, is often mentioned when we're talking about palliative care, reducing pain, medical care for patients with terminal illness and in need of pain relief. And there's a couple of great illustrations I have. There's one of a nurse, not a nurse, but a physician resident who walks into a patient's room. Patient's been suffering greatly from illness, and the patient looks up at this resident and just says, "Let's get this over with." And the resident proceeds just to go ahead and inject a massive dose of morphine. She understood what the patient wanted. She understood how to make it happen. In that case, she was intending to cause the patient's death, we would think, rather than just reduce pain. On another hand, I remember a case where a young physician resident was treating a person with cancer that was just terribly painful as these little tumors just kept bursting through his skin. And while he was not wholly conscious, his family was around and they really hated the pain, his suffering, and they said, "Can't you do anything about this?" And so the physician started to increase the administration of the pain medication, probably morphine in this case, and kept increasing it to the point that the respiration slowed and the patient eventually died. The family breathed a sigh of relief when that happened, but I remember following that resident around to his office down the hallway, and I walked in there and he was just sitting on his desk with his elbows on his knees, and I looked at him and he looked at me and he said, "I'm just not sure what I did in there." And he was experiencing that dilemma between reducing pain and causing death. So the question would be, what did he do? Was he intending to reduce pain or intending to cause death? I think in that example, his intention was to reduce pain, knowing that the outcome would be death. Now, there's three assumptions that operate in the background of these discussions. One, and you may not agree with these, but generally they're agreed upon assumptions. It's assumed that the side effect of hastening death is an inevitable or at least a likely result of the administration of opioid drugs to relieve pain. It's just assumed that if we keep increasing these high-powered drugs, these opioids, death will occur even though we're striving to reduce pain. Second, then we assume the hastening of death is not unwelcome. It's a side effect of providing pain relief, but it's not unwelcome if we're doing it in the context of palliative care. And palliative care, you probably know, is that care for patients within what we think is the last 6 months of their life. It is a treatment regimen where no therapeutic treatment is given, only pain management is given. And so in this case, the hastening of death is not unwelcome because the patient knows that under palliative care, he or she is going to die shortly, and usually those patients say the sooner the better. Now, third, it's also assumed that it would be impermissible to hasten death intentionally in order to cut short the suffering of a terminally ill patient. Now, I list here several items from the ERDs. I've got the actual booklet of the Ethical and Religious Directives. You've got it online. But I'm going to look at these four that I've highlighted here. And the ERDs use the terms of ordinary and extraordinary means. And ordinary means that which is likely to offer reasonable hope of benefit, and extraordinary is a means that is not going to be successful in relieving pain or providing benefit to the patient. So number 57 says, a person may forego extraordinary or disproportionate means of preserving life. Disproportionate means are those that in the patient's judgment, not anybody else's, but the patient's judgment, do not offer a reasonable hope of benefit or entail an excessive burden or impose excessive expense on the family or the community. And that's an interesting final phrase there. Excessive expense for the family or community is also a factor. Now, number 58 says, in principle, there is an obligation to provide patients with food and water, including medically assisted nutrition and hydration for those who cannot take food orally. And this obligation extends to patients in chronic and presumably irreversible conditions. Medically assisted nutrition and hydration, however, become morally optional when they cannot reasonably be expected to prolong life or when they would be excessively burdensome for the patient or cause significant physical discomfort, for example, resulting from the complications in the use of the means employed. Number 59. The free and informed judgment made by a competent adult patient concerning the use of withdrawal of life-sustaining procedures should always be respected and normally complied with. And in this case it says, unless it is contrary to Catholic moral teaching, and that would not be a relevant factor to everybody. Finally, just to add to this, euthanasia is an action or omission that of itself or by intention causes death in order to alleviate suffering, and that is not allowable in Catholic healthcare ethics, and it's not allowable under the laws of any state in the United States. So that kind of gives you a summary of how it's treated here, and I'll reiterate, I've not given you these directives from the Catholic Church because I think I want you all to perform according to Catholic moral theology, but because I think it's a great articulation of moral issues that occurs in healthcare. And then you can decide if you agree or disagree with one of them, but when you decide to disagree, you need to be sure you can articulate your reasoning. Let's go on. Now here's a normative view from the ERDs. A doctor believes that abortion is wrong, even in order to save the mother's life. But that doctor might nevertheless consistently believe that it would be permissible to perform a hysterectomy on a pregnant woman with cancer. In carrying out the hysterectomy, the doctor would aim to save the woman's life while merely seeing actually the unavoidable death of the fetus. Performing an abortion, by contrast, would involve intending to kill the fetus as a means to saving the mother. You see, it's an issue of which is intended, which comes first. And remember we said the good outcome must not be the result of the bad outcome. Only the bad outcome can be a secondary result of the good outcome. To kill a person whom you know to be plotting to kill you would be impermissible because it would be a case of intentional killing. However, to strike in self-defense against an aggressor is permissible, even if one foresees that the blow by which one defends oneself will be fatal. Are you beginning to see the difference here? It's a matter of intention. And if we go back to Immanuel Kant in Deontology, and he talks about these necessary duties that exist for all persons, he says what's important is the intention of the agent. Not the outcome, that would be consequentialism, but the intention of the agent. And if the intention of the agent is correct, is justifiable, then any outcome is acceptable, even if we don't like the outcome. Another example. It would be wrong to throw someone into the path of a runaway trolley. This is an old-fashioned example, isn't it? A person must live in San Francisco. The path of a runaway trolley in order to stop it and keep it from hitting 5 people on the track ahead. That would involve intending harm to the one as a means of saving the 5 if I throw someone else onto the track. But it would be permissible to divert a runaway trolley onto a track holding 1 and away from a track holding 5 In that case, one foresees the death of one as a side effect of saving the 5, but one does not intend it. So you go for the best outcome in this case and cause the death of as few people as possible. Another example, sacrificing one's own life in order to save the lives of others can be distinguished from suicide by characterizing the agent's intention. And this is a good example from the battle theater. A soldier who throws himself on a live grenade intends to shield others from its blast and merely foresees his own death. And in fact, so often we hear stories where people think the person who takes that action is not even aware of the possibility of his own death. He's totally focused on saving the lives of his compatriots. By contrast, a person who commits suicide intends to bring his or her own life to an end. Now, here's 3 examples from healthcare, and I draw these are from Catholic healthcare issues, from a textbook on Catholic healthcare. And I use them because it's interesting to see how the reasoning works here. You don't have to accept the reasoning, but here's how it works. And we read some of this. Now, abortion is the first one. We've talked about a little bit already. A direct abortion are those in which the act itself is the removal of the fetus directly from the body of the woman or the direct killing of the fetus by any other means while still in the mother's body. That's an abortion. And Catholic ERD say these acts are never permitted and are considered gravely immoral, identical to murder. More about that in a little bit. Indirect abortions, however, are permitted according to the principle of double effect. The act in itself is specified as an operation or other procedure whose directly intended effect is the preservation or restoration of the mother's health. The foreseen but nevertheless unintended death of the fetus is indirect. Now, you may think that's splitting hairs because if you know just as surely that the fetus will die as you are that the mother won't die, then you could call that a direct effect. But under the rule of double effect, this would be allowable. Also, we can look at life-sustaining treatment, euthanasia, and PDE. We gave you those examples of the administration of medications. Are we giving the medication in order to reduce pain, to sustain life, or are we doing it with the intention of hastening death? It makes a difference in whether it is ethically allowable or not. Finally, I'll throw contraception in here as well. It's one that's argued in the Catholic textbooks. And as most of you are probably aware, contraception is still prohibited in the Catholic Church, although it is widely used by those who are Catholic. But oral contraceptives may be used when their contraceptive or sterilizing effects are indirect. Now, you use the drugs for contraceptive purposes, that's prohibited. But if you use it for reasons other than contraception, even though contraception is an indirect, unintended side effect, then it's all right. Consider, direct effect is prophylaxis against the transmission of AIDS, but you're also still preventing pregnancy. That's the indirect effect. And you can think of other medical conditions that may be treated by contraceptive drugs, but the direct effect is to serve the medical purpose. The indirect effect is to prevent possible pregnancy. In that case, it's allowable. Here's some more cases that I get you to think about. We won't talk about all these, but you can see how they affix to the ones we've talked about already. Removing of a pregnant cancerous uterus, we did talk about that one. The removal of a fallopian tube in the case of ectopic pregnancy. The use of and that's prohibited in the EDRs, by the way. Use of medications on a pregnant woman to address some other condition with some danger that the fetus could die. An appendectomy on a pregnant woman, even though some or great danger exists of a consequent abortion or miscarriage, we would call it in that case. Opioid pain management on a terminally ill patient, we've discussed. And finally, I mentioned the Phoenix case. I have posted this case on our webpage for this week if you want to read through it in detail. But it's an interesting case, and I'll give you just some of the highlights of it. It's about a person named Margaret McBride. And this occurred with the sanctioning of the American Religious Sisters. She is a religious. November of 2009 of an abortion at a Roman Catholic hospital in Phoenix. Now, Sister Mary McBride, a Sister of Mercy, was the administrator at this hospital, and as an administrator was also a member of the ethics committee. And part of her purpose in being on the ethics committee was to be a spokesperson for the mission and ethical code of the medical center. Well, she was a member of the ethics committee at St. Joseph Hospital in Phoenix, and the committee was consulted on the case of a 27-year-old woman who was 11 weeks pregnant with her 5th child, and she was suffering from pulmonary hypertension. Her doctor said the woman's chance of dying if the pregnancy was allowed to continue was close to 100%. So in the doctor's view, we terminate the pregnancy, she lives. We don't terminate the pregnancy, she and the fetus both die. Well, McBride joined the ethics committee in approving the decision to terminate the pregnancy through an induced abortion, and the mother survived. Now understand, the ERDs say specifically you cannot do an abortion, but they say if you're treating another pathological condition, it may be allowable. Well, when the bishop got hold of this, the bishop informed her that in allowing the abortion, she had incurred an automatic excommunication from the church. And so she was removed from her post as vice president of mission integration at the hospital. It reached the newspapers, and there was a great deal of discussion. And finally, in December of that year, Olmsted announced, that's the bishop, that the Roman Catholic Diocese of Phoenix was severing its affiliation with that hospital after months of discussion, had failed to obtain from the hospital management a promise never to perform abortions in the future. They would not do it. They said, if we are presented with a situation in which a pregnancy threatens a woman's life, our first priority is to save both the patients. If that is not possible, we will always save the life we can save. And that's what we did in this case. And they continued, morally, ethically, and legally, we simply cannot stand by and let someone die whose life we might be able to save. Well, after the hospital changed hands, eventually Sister Mary was no longer excommunicated. She was put in good standing with the Sisters of Mercy. Now, there were reactions to all of this, of course. The ERDs are what we're quoting here, and I've read some of these to you before. But if we look at the ERDs, let's see which numbers I'm using here. Well, they're in 45 and 47, I believe they are. But the ERDs don't provide all the answers. In this case, it might be argued. Directive 47 is where it starts. And I've alluded to this one, but let me read you part of it. Directive 47 says, operations, treatments, and medications that have as their direct purpose the cure of a proportionately serious pathological condition of a pregnant woman are permitted when they cannot be safely postponed until the unborn child is viable, even if they will result in the death of the unborn child. That's where it begins. But Directive, let me jump ahead here. Directive 45 had just said, abortion before viability or the directly intended destruction of a viable fetus is never permitted. Every procedure whose sole immediate effect is the termination of pregnancy before viability is an abortion, period. So they have the one rule and then the exception to the rule. And of course, those who supported the action of the ethics committee in that case, they believed that it was justifiable. They argued that People needed to know if they came into the hospital that the hospital was going to do everything possible to save their lives. And I've always wondered if patients are fully informed about these kinds of restrictions when they are admitted into a Catholic hospital. They may not be going to a Catholic hospital because it's Catholic. They're going to it because that's where their physician practices, or it's the one that's closest to home. And one person pointed out as well, and says, this is interesting that she was excommunicated for allowing a life to be saved, but at the same time, no priests have been excommunicated for sexual abuse, suggesting a double standard within the church. Some people would argue that that's apples and oranges, but it seems like a pretty good argument to me. That's a good real-life illustration of how these ERDs create consternation of those people who are trying to make the decisions in these hospitals and still try to be faithful to the ethical and religious directives. Sometimes people feel that they have to be violated in good conscience. Sometimes you're led to breaking a rule because you think it's the right thing to do. In public service, we'd say that's the civil disobedience. We see what the law says, but we know in this case it is not the best thing to do to get the best outcome, and we believe we can justify breaking that law or that rule. So there's some examples of how all of this works.